Well, it's about time. Good afternoon and welcome to Grand Rounds. Today we have very special Grand Rounds in infectious diseases. It's my pleasure to introduce Dr. Geeta Subravarian. She's the Chief of Hematology Oncology for Infectious Diseases. She was also the prior Fellowship Program Director. She has passionate and really interested in studying fungal infections, especially Cooksey infections. She has collaborated with local communities and internationally in study of this disease. She brings a lot of expertise. She is on a lot of journal manuscripts, particularly studying Cooksey in Central Valley. So without further delay, I would like to invite Dr. Geeta Subravarian to further the Grand Rounds.
Thank you for the kind introduction. I welcome everyone for today's UCSF Fresno Department of Medicine Grand Rounds. Although this is Department of Medicine Grand Rounds, it's actually a platform today for a national update. We are bringing together a wider group of audience of over 300 people registered from across the region and the country, representing multiple disciplines. And we want to discuss a very critical topic, important topic for us in Central California, that's valley fever. This program truly reflects a collaborative effort with our public health partners. And together we have assembled clinical and public health updates to share with you today. To provide context, to provide more context for valley fever in our region, we have speakers from Fresno County Public Health, which is a high incidence county, Merced County Public Health, which represents both the high incidence and emerging patterns, and Stanislaus County Public Health, an area of emerging incidence. They will share the characteristics of valley fever in their counties, followed by a broader statewide perspective from California Department of Public Health. So please join me in welcoming our public health partners who will share their expertise and regional perspectives. Joining me today are Gail Cooksey. She's an epidemiologist in CDPH Infectious Disease Branch. Her work focuses on surveillance, outbreak investigation, and provider and public awareness efforts for mycotic diseases, particularly valley fever. Dr. Ellora Karmarkar, she's a public health medical officer in the infectious disease branch at California Department of Public Health. She supports valley fever activities, including surveillance, outbreak investigation, and provider awareness for mycotic diseases. Matthew Middleton has been with the epidemiology program at the Fresno County Department of Public Health since 2016. He serves as the lead epidemiologist for the TB program and contributes to infectious diseases surveillance in Fresno County, including valley fever. Dr. Ignacio Santana is a public health officer for Merced County Department of Public Health, where he oversees infectious disease control and public health policy. A UCSF trained specialist in occupational, environmental, and climate medicine with an MPH from UC Berkeley and an MD from Brown University, he focuses on health equity for agricultural underserved populations. He leverages his clinical research background and native Spanish fluency to improve healthcare access across the region. And last but not the least, Dr. Papa. She serves as the public health officer for Stanislaus County. She joined the Stanislaus County Health Services Agency Public Health in 2018 as the assistant public health officer and has held several roles, including communicable disease and tuberculosis controller. She earned her MD and MPH from University of Texas Health Sciences Center at Houston and BA from Johns Hopkins University. She's board certified in public health and general preventative medicine, having completed a residency at University of South Carolina Palmetto Health. So with all of us, the way we're going to do this is it's going to be a combined effort. I'm going to start off with a case that's relevant to bring the valley fever perspective, and then we'll move on to our public health partners, and then we'll come back to the clinical updates towards the end of the talk. So let me start with the case. So this is a case that we came across here. I've changed the name a little bit, the demographics a little bit to protect the patient's anonymity. This is a 36-year-old male who works in construction. He has a 10-pack-year smoking history, has no other health conditions. He presented with a 3-week history of shortness of breath and dry cough. Initially, he was treated empirically with azithromycin and later doxycycline with no improvement. He had heard of a few cases of valley fever at work and spoke to his primary care physician about it. And so his primary care physician ordered valley fever labs for him, but he became very sick. He had not been able to get these labs done. He did go on to develop fevers up to 104, night sweats, a 10-pound unintentional weight loss. So his symptoms had been ongoing for a month, but he had marked worsening of his symptoms about 4 days, which prior to his ED visit. The ED visit was prompted because he was very short of breath, and in the ED, he was noted to be hypoxic, tachypneic, tachycardic. He had a fever of 101, and he was needing oxygen supplementation too. So he was admitted to the hospital. A Cooksey EIA screening test was sent out. Infectious disease was consulted, and he was started on broad spectrum IV antibiotics with vancomycin, piperacillin, tazobactam, azithromycin. The next day, he was also started on fluconazole. His Cooksey studies that were sent by EIA by screening did come back positive. This was his admission CT scan. I'm going to let it roll there for a second. As you can see, he had diffuse bilateral reticulonodular infiltrates, and which is an uncommon presentation with valley fever, but when it does present, patients do poorly, unfortunately. So his Cooksey screening test did come back positive. He was switched over to intravenous amphotericin B. However, he progressively worsened over the next 4 days. And eventually he got intubated, but unfortunately he expired due to respiratory failure and cardiac arrest. Later, the confirmation test for immunodiffusion for valley fever came back positive, and his blood cultures actually grew the valley fever fungus as well. So this case is difficult. It's a difficult case, but unfortunately, it's not unique in our region. It highlights the real consequences of delayed recognition and the broader patterns we continue to see across the Central Valley. So to better understand what's happening at a population level, I'm going to now turn it over to our county public health partners who will share brief updates and trends in their counties, followed by Gail and Ellora from CDPH, who will provide a broader overview of the California data. After their updates, we'll return to the clinical perspective, including diagnostics and management considerations. With that, I would like to now invite Matthew Middleton from Fresno County Public Health to share the Fresno County's data. I'll stop sharing. And Matthew, go forward. Thank you.
Great, thank you very much. Can everybody see my screen okay?
Yes.
Great. Good afternoon, everybody. I'm Matthew Middleton. I'm with the Fresno County Department of Public Health. Appreciate me being here today to speak to everybody. And I have a few slides for you today. We've got a packed presentation for you. But I wanted to talk about valley fever incidents here in Fresno County. So this data at the top here is showing you the number of valley fever cases that we've seen in our health jurisdiction all the way back to 2010, all the way to currently to 2025. And hopefully you can tell during the most recent years, 2024, 2025, we saw a large increase in the number of Coccidioidomycosis cases that were being diagnosed here in Fresno County. And when we look at 2021, there are 410 cases, and compare that to 2024, that represents about 164% increase in the number of valley fever cases diagnosed. And in 2024, that's the most number of cases we've seen all the way back to 2010. 2025 ended up being a strong year as well for valley fever cases at 1,012 cases. And we look at the incidence of these cases per 100,000 Fresno County residents. In 2024, 106.2 residents per 100,000 population had valley fever. And then in 2025, that dropped a little bit, but not much, at 98.8 per 100,000 population. What's interesting about valley fever in Fresno County is there's a strong geographic trend where we see valley fever in the county. And most valley fever is actually found in the western or southwestern parts of the Central Valley. So this data is showing you the incidence of valley fever in incorporated cities from Fresno County. And hopefully you can tell that some of these incorporated cities pop out for their incidence of valley fever. And typically we see valley fever in the communities of Coalinga, Huron, Mendota, and Firebaugh. And if we looked at the 2024 year, remember that was that high incidence, high case count year that I just described. And that year, Coalinga itself, as valley fever incident, was 21 times higher than that of Fresno counties as a whole. And Huron, which was in the second most highest incident in 2024, its incidence was 7 times higher than Fresno County as a whole. And when we look at the communities of Coalinga, Huron, Mendota, and Firebaugh combined in 2024, they reported nearly 1/2 of all valley fever cases in Fresno County, despite only having less than 5% of our total county's population. So this area of the county is highly endemic for valley fever. And then moving along here, I wanted to show this figure for you, which shows the incidence of valley fever in Fresno County by zip code. And the darker red areas are showing you that those higher incidence areas of valley fever with those communities I mentioned showing the highest burden. The graph on the right there is showing you that the incidence per 1,000 population for each of those zip codes and corresponds to the zip codes that's on the graph there on the left. So that's all I have to share today with the group. There'll be some other great updates from my other colleagues coming next. Thank you very much. I look forward to answering questions later on in the presentation.
Thank you, Matthew. Dr. Santana, if you want to share your slides from Merced next, please.
There we go. Hope you can all hear me. I hope. All right. Hello, everyone. I am Dr. Ignacio Santana. I am the Public Health Officer in Merced County, and I'm going to be speaking to you today about valley fever in Merced County specifically. So thank you very much for coming. The first graph that I want to show you has to do with valley fever cases in Merced County overall, very similar to what our colleagues in Fresno just did. It spans from 2021 to 2025. 2026 technically. But I do want to highlight that there's just a clear upward trend in valley fever cases over the last few years. There was a peak year in 2024 where we saw approximately 213 cases, which is a significant jump from 97 cases just a couple of years prior. Cases subsequently dropped to 160 in 2025, which is an improvement, but still significantly higher than levels that we've seen previously. And so that just means that levels remain elevated compared to historic baselines. I also want to use this as an opportunity to point out that there is a monthly seasonality to this, right? And we'll talk about this a little bit later, but data reveals that there's a seasonal nature, and that probably correlates with ag cycles and or weather patterns that are typical within the Central Valley. In this next graph, we see a distribution of age among valley fever cases from 2010 to 2025. So this one spans a longer period of time than the data I just showed before. But this is a good opportunity to highlight that it's ages 50 to about 70 that make up 40% of our cases here in Merced. And so that could be for a variety of reasons, comorbidities being one of them, but we'll talk about that later as well. On a related note, we also see that there is kind of a youth-sparing tendency with this disease, in that this makes up approximately 6% of cases. So from children to teenagers, basically 0 to 19 years old, we see the incidence drop pretty starkly. In this next image, I want to highlight the big cities that we have here in Merced County specifically. The big cities being Merced, with approximately 28.3% of all cases, as well as Los Baños, which is 32.8% of cases. This is expected given that they are larger cities in our county, and so would have a larger population, therefore a larger proportion of people who have valley fever. However, I do want to highlight these three cities: Atwater, Dos Palos, and Gustin. These are much smaller communities, more rural, more working class, and so they also have very large proportions, 9.8 in Gustin, 6.8 in Dos Palos, 9.4 in Atwater, which is unusual in that because they're much smaller communities, they still have a high incidence, a high burden of disease. And so that could be for a variety of reasons, the type of work that people do, There's just a lot of correlations that have to do with it. But I wanted to use this as an opportunity to highlight that Los Banos is our epicenter, but there are other areas that similarly have high incidence of disease. The next few slides are basically, they'll highlight the clusters that we see in the entire county as well as in specific cities. So this is for Merced County. We again see the clusters in Los Banos, Merced, and then as I had mentioned earlier, and this is another way of viewing the same data, this is density of cases. Los Palos, Gustin, and Atwater are also pretty strikingly obvious. In Merced itself, the city, we see a clustering of cases basically in the downtown area, as well as this here is Highway 99. We see it southwest, just like we had heard about Fresno. There tends to be a clustering of cases, not only within cities in the southwest side, but also the western part of the county. So just an interesting note there. And the last image that I have is Los Banos. And so again, we see a clustering. This is the highest incidence of disease, and then a clustering on the west side, as I had mentioned. And with that, I yield, I thank you for your time, and I yield my time as well.
Dr. Papa, do you want to share your slides, please? Thank you.
Dr. Papa, you're on mute, just FYI.
Are y'all seeing any of my slides?
Yes.
Oh, okay. Well, I can't, let's see. So I'll just, we'll get started. So we're going to look at the epidemiology of valley fever in Stanislaus County. So we're marching northward. Fresno is the southernmost of our three counties, then Merced, and then Stanislaus. So hopefully is it showing up? Okay, let's see. So looking at our case counts and our case rates for the last 5 years or so, we can see that there's definitely been a general upward trend, but there are some years where we do have less cases. So in 2022, we did have lower case numbers. And again, following similar trends, we saw an increase in our case counts in 2024, very high, and then it went back down, but still higher than it had been previously. And if we look at our actual case rates, which looks at our case counts broken down by our population, we can see that there is a general upward trend. So the next slide, we're going to look at our case count in our county, just looking over time and breaking it down by month. And we can see, again, for 2024, which is this gray line here, and we saw also in 2023 that there were a high number of cases, especially towards the late summer, early fall, early into winter. There was a high number of cases. And we can also see that in general that there was just an overall elevated number of cases in 24, as well as throughout much of 2025. And now we're going to look at, we're going to break down our case counts. This is actually our case rate by some of our major cities in Stanislaus County. So looking at this, we can see obviously that the highest case rates, we saw the gray bars were from 2024, and we saw really high case rates on these two cities, Newman and Patterson, which are both on the west side of the city, or west side of our county. But these are case rates, so that doesn't necessarily mean they had the most the highest number of Coccidioidomycosis cases, but per population, they were definitely a standout. We can also see with the with the orange in 2025, that case rates started to come down. There was definitely a decrease in Patterson, nearly half the case rate as it was from its peak in 2024. We also saw in Salida, for whatever reason, it continued to have this upward climb in 2025. And now we're going to just look at breaking it down again by some of our most populous cities over the years, looking at both the case numbers and the case rates. We did suppress some of the case numbers just because there was too small of a cell count. But in general, if you look at Modesto, which is our most populous city, it's the county seat in Stanislaus County. We definitely see from 2021 to 2025 an increase in the overall number of cases. So we went from 55, in 2024, we had 105, a peak, and then we went back down to 75. But if we look here in Patterson and Newman, which again are those cities on the west side, they started off much lower, but they had a big dramatic increase in their case rate, up to, for Patterson, all the way up to 300, about 300 case rate in 2024, and then that came back down in 2025, but still overall increased from where it had been. And then in Salida, which is just north of Modesto, we did see that in 2025, it was still increased compared to the previous year. And now we'll just look at it by just the geography of our county. So here, the west side, if you can see some of in 2024, the bluer area, that's where Patterson and Newman are. So you can see just, we were seeing a much higher case rate and case distribution in those areas. And then just the general trend from 2022 to 2024, we really did see an increase in the case rate, which came down a little bit in 2025. Looking at our overall number of cases our combined number of cases from 23 to 2025 in Stanislaus County, just looking at our distribution of between male and female, we saw a higher number overall of cases in males. And looking at it by race and ethnicity, we saw, I did also suppress some of these case counts just because they had a very small case number. But in general, we see our Stanislaus County, the two major ethnicities making up Stanislaus County are Hispanic and white. And we saw that that's sort of reflected in our case count, where most of these cases we see in Hispanics and whites, but with an overall higher case rate in whites. Also in Asians, we saw the actual case rate was higher in Asians. That's all I have, and I will turn it back to the team.
Thanks, Dr. Papa. Gail, do you want to start with the California-wide data for us?
Sure. Thanks, Geeta. So I will dive right in, stepping back a little bit. Hello, everybody, from the state health department perspective, giving a little bit of a broader view here. So to back up even sort of internationally in terms of Coccidioidomycosis endemicity, this is a disease of the Americas, with over 97% of our cases in the US in just two states, Arizona and California. But we also do find Coccidioidomycosis in parts of Eastern Washington, Utah, New Mexico, Nevada, Texas, and then also Mexico and Central and South America. And you've heard from a few counties in California, but in general, California's highest rates are in the Central Valley and the Central Coast, which historically have the highest rates. And you can see that on this map in the darker colors. And we've heard a lot already about the increasing rates in California, and we've seen this at the state level as well. And I won't spend too much time on this, but we'll just highlight that 2024 was a record year in the state as well, with over 12,000 cases reported in California as a whole. And that did continue into 2025, where I think at the end of the year, when we have everything finalized, we'll have close to 11,000 cases. But I do want to emphasize, even as much as the increase, that one of the big things we're seeing statewide with Cooksey is that it's expanding to more parts of the state. So not just what we might historically think of as the Central Valley or Kern County. And on the map in 2001, you can see these are rates by county in California. And really, those Southern San Joaquin Valley counties are standing out in the darker colors. But if you compare that to 2024, you can see how much more of the state of California is now in these darker colors, indicating higher rates of valley fever. And we really want you to take away from this talk today that this is not just a Central Valley issue anymore in California. It is expanding to a lot more of our neighboring areas. And the big question is why? And it's likely multifactorial. One issue that I'll talk about in the next couple of slides is winter rains after drought. But also, this is caused by a fungus that lives in the dirt and soil. So it's going to be heavily impacted by climate and environmental factors and climate change. Also, locally, if there's soil disturbing activities like big projects happening, that could get more of the fungus into the air when it can be breathed in. Also, the movement of susceptible people to endemic areas, and then changes in diagnosis and reporting can impact trends. But one of the big things we've done at the state is partner with academic modelers to try to look at what environmental climate factors are impacting valley fever in California. And our biggest finding so far is that we have this pretty clear trend of seeing surges in valley fever at the end of droughts. So this graph here shows droughts in orange and brown, and the black line are Cooksey cases. And you see these clear peaks in between our droughts. And our modeling work has helped us find that what the trend is that when we have multi-year droughts followed by heavy rains in the winter, we see high Cooksey surges in the following years. And that's exactly what we saw most recently over here in 2023 through 2025. We had the end of a drought and heavy rains return and a large surge. And we're not just seeing and predicting that Cooksey is going to expand in the state of California, but there's also models looking at climate change that it could expand into more parts of the United States as well. You've heard a little bit about demographics. At the state level, we also consistently see higher rates in males than female, twice the rates of hospitalizations in males than female. Incidence increases with age, but we do see severe disease in peds, even though it is our lowest rates. And then race ethnicity is a little hard to look at because of missing data, but we see more disease in Hispanic and Latino populations and Black populations than we would expect, and high rates of hospitalization and severe disease in Black populations. And then really briefly, even though this doesn't always come up as much in clinical care, in terms of risk reduction and prevention, we do have practical recommendations on our valley fever webpage about reducing dirt and dust exposure to prevent valley fever, especially in outdoor workers who can be heavily exposed. But some of the main takeaways here are that this is really difficult to prevent and avoid breathing in dust. And even a small dose, just driving through an area, can lead to infection. So we're really relying on increasing provider and public awareness to encourage earlier presentation to care and testing. And hopefully that will help reduce poor outcomes in valley fever. And I'm going to pass it over to Dr. Ellora Karmarkar.
All right, can everyone see my screen?
Yes.
Great. All right, so I am going to kick us off with the clinical overview before I hand off to Dr. Siva Subramanian again. And I think it's really important for us to remember that Coccidioidomycosis can pretend to be many things and present in many different ways, especially when we think about the challenges of diagnosis. This is a really tough disease to diagnose. And so one example is, for example, usually when we're taught about Coccidioidomycosis, we think of nodules on a chest x-ray as classic, but it's important to remember that Coccidioidomycosis can also present with these lingular consolidations or multifocal consolidations, and it looks a lot like a bacterial pneumonia. Coccidioidomycosis can also look like cancer, those symptoms of weight loss, night sweats, fatigue associated with a lung mass on chest imaging can be very suspicious for malignancy. Patients can be sent to lung nodule clinic due to concern for cancer, biopsied, and then the pathology can show coccidioidomycosis. Sometimes patients come in with unexplained ARDS, and it's presumed to be bacterial sepsis or bacterial pneumonia, but it's important to remember it can also be caused by Coccidioidomycosis. And then sometimes when Coccidioidomycosis disseminates to the spinal cord or the abdomen, it can look like masses or it can look like abscesses that could be tuberculosis or malignancy. These are all examples of how Coccidioidomycosis can be tricky to diagnose if you're not thinking of it. So let's back up and start with a broad overview of coccidioidomycosis. So Coccidioidomycosis usually presents as a respiratory illness with cough, fever, chest pain, and fatigue, with 5 to 10% of people developing severe pneumonia. Sometimes people can present with raised nodules on their legs, known as erythema nodosum. That's a classic symptom of valley fever. But the diagnosis of Coccidioidomycosis can be very challenging. Not only the imaging, but the symptoms can mimic COVID-19, influenza, viral or bacterial pneumonia, or other fungal pneumonia. And as shown earlier, sometimes it can mimic TB or malignancy in the lungs. In terms of management, some patients improve on their own and don't need treatment, but do need monitoring over time. And patients with severe or progressive illness do need treatment with an antifungal agent, and Dr. Siva Subramanian will go into more detail about that later in the talk. In severe cases, patients develop disseminated disease. So that means the coccidioides fungus spreads to bones, joints, skin, or to cerebrospinal fluid. And important to note that this can occur with or without respiratory symptoms. So that classic presentation of Coccidioidomycosis doesn't always happen. It's really important to review patients who look like they just have respiratory disease to make sure they don't have any signs of dissemination. And sometimes any respiratory symptoms a patient does have develop and then disappear. They're brief. And so that can make disseminated disease much more challenging to diagnose. That disseminated Coccidioidomycosis can be severe, chronic, and even fatal. It can require prolonged treatment, and in some manifestations requires lifelong treatment. So what's the general timeline for illness? It takes about 7 to 21 days for a patient to develop illness after being exposed to the dirt and dust that contains the coccidioides fungus. The median time to diagnosis after developing symptoms is about 27 days, so nearly a month, but it can be as long as several months, as we discussed, given how challenging it is to diagnose Coccidioidomycosis. In our work at the state, we see those delays in diagnosis and risk for misdiagnosis, including a study where we interviewed 400 patients throughout California who had recently tested positive for Coccidioidomycosis. 50% had been treated with antibiotics before they were formally diagnosed, and it took a median of 27 days after symptom onset for them to be even tested. And this is similar to findings from Arizona, another endemic area, which demonstrated similar patterns in antibiotic prescriptions, delays in diagnosis, and they also identified increases in healthcare system costs from delayed diagnosis. So this affects our entire healthcare system. We also want to highlight that Coccidioidomycosis can be a very debilitating and severe illness for patients. So it's really important that they get diagnosed and that they get into care. Of the patients we interviewed, only 24% were recovered at the time of interview, and we interviewed most people about 2 months after their onset of illness. 73% missed work or school for a median of 13 days, and a third of them were hospitalized, with 20% of those hospitalized patients requiring ICU care. So how should we know when to test for Coccidioidomycosis, given how complicated Coccidioidomycosis can be? So we're going to walk through these 3 things to watch for from our perspective in California. First, determine if the patient's been symptomatic for more than 7 to 10 days with respiratory symptoms and constitutional symptoms. So these symptoms are outlined in that leftmost column and might include cough, trouble breathing, fever or night sweats, fatigue or tiredness, chest pain, joint pain, rash, and or weight loss. Additionally, any prior antibiotic treatment that they might have received wouldn't have helped those symptoms get better or completely resolve. Second, so important, take a thorough social history. Identify if they lived, worked, went to school, or traveled in a high incidence or emerging incidence region, even if for just a short time, as even a few fungal spores can cause someone to become sick. For California, referring to a map like this in the middle column, which is available on our website as a public dashboard, can help identify whether the patient spent any time in areas where Coccidioidomycosis is present or emerging. Travel can be a risk factor that is often overlooked, especially for out-of-state visitors who come to California or other endemic areas like Arizona, spend time for a short trip, and then return to areas where Coccidioidomycosis is not as common and providers are less familiar. Third, consider if the patient has a known exposure to dust or dirt, either from their work or from an outdoor event or activity, as mentioned in the last column on this slide. We'll go over work-related risk factors, but it could include construction, firefighting, or any other outdoor work. This combination of 3 factors can help identify if Coccidioidomycosis testing should be considered. But I do want to reiterate, based on the presentations you've heard from our county colleagues, simply living in a high incidence or emerging incidence area like Fresno, Merced, or Stanislaus is a sufficient exposure to develop valley fever, even if someone's been living there for a long time without becoming sick. When talking about work risk factors, when getting that social history, it's important to ask probing questions about a person's job, because sometimes that person's job title might not indicate work-related dirt or dust exposure. High-risk occupation could include an electrician laying wire and recently dug trenches for a solar farm, or a firefighter digging fire lines to prevent the spread of wildfires. However, an accountant working from a trailer on a construction site, while not doing the dirt-disturbing work, could still be exposed to the dirt and dust in the air in a way that could increase their potential likelihood of acquiring valley fever. Additionally, travel can even be an overlapping risk factor, with people traveling to high-incidence areas to work on a solar farm or assist in fighting a fire. So all those detailed questions are really important to ask when determining someone's risk of valley fever. Not only is the social history helpful to identify risk factors for acquiring disease, it can also potentially identify outbreaks. Our surveillance system is based only on laboratory reporting, and so we can't get the same detailed history a provider can. When providers pick up shared exposures, that's sometimes a clue that there may be an ongoing outbreak. We get our outbreak notifications through whistleblowers, employees or employers, and you, the healthcare providers. We've worked on a variety of outbreaks related to outdoor workers in construction and firefighting, but also outbreaks associated with outdoor events. And I want to highlight that for a recent outbreak at a music festival, that was actually picked up first by medical providers who noticed a shared exposure and reported to us. And emphasizing the importance of a travel history, the most important risk factors for these patients were travel from their residence to a high incidence area, even for a very short-term trip, and exposure to dirt and dust. So we've reviewed groups at higher risk of infection based on where they live, travel, go to school, or work, if it's in a high incidence or emerging area, or outdoor workers, or people who are exposed to outdoor dirt and dust. But there are also a few key groups at increased risk of severe disease if infected, including older adults over 60, people of certain racial ethnic categories, like if they're Black or Filipino or Hispanic Latino, pregnant women, especially in later stages of pregnancy, people with diabetes, and people with immunocompromising conditions or on immunosuppressive medication. But as Gail mentioned earlier, it's important to remember that healthy people can get Coccidioidomycosis and healthy people can get severe disease. Based on the enhanced surveillance project we did, most patients who acquired Coccidioidomycosis we interviewed didn't actually have any underlying medical conditions, and the most common condition reported was diabetes. Recognizing, diagnosing, and managing Coccidioidomycosis can be challenging, but there's many resources available, including the IDSA guidelines, a handbook from the Arizona Department of Public Health, and other clinical resources. But one of your best resources is your local clinical subject matter expert, Dr. Siva Subramanian. So I'll hand it off to her to talk a little bit more about diagnosis and management.
Thanks so much, Ellora and Gail, and all our county public health partners. So I'm going to move on from the clinical aspects to the diagnosis and management. And as Dr. Karmarkar mentioned, it is very hard. Diagnosis and management of valley fever is hard. And, valley fever, as we saw already, is very common in our region. It's It's a common disease, but it's not a simple disease. So despite how frequently we see it, it remains challenging to diagnose and manage, even for experienced clinicians. This raises an important question. Why does a disease we encounter so often remain so difficult to recognize and treat? Because valley fever places unique demands on the care system. And the next question becomes, why does it do so? Why does valley fever place these unique demands on the care system? What makes it unique? So there are a few things. It presents like a common illness, but it has an unpredictable clinical trajectory. So it can mimic a viral illness. It can mimic a routine community-acquired pneumonia. Many recover, but others developed prolonged, complicated, and disseminated disease. So it's very hard to predict in the beginning which of these patients are going to go on to recover well and which of these patients are going on to develop a more complicated or disseminated course. So early recognition is necessary, but it is insufficient. Diagnosis unfolds across encounters and not a single visit. So diagnosis is indirect and iterative. There is no point of care test. Serologies may be negative early on or require repetition. And interpretation requires context and follow-up and not a single visit. As you can imagine, many of our patients that we see in Central Valley do not have access to primary care physicians, do not have access to longitudinal care, and they rely on urgent care visits and emergency room visits for their care. And valley fever is not something that can be diagnosed and treated in a one-time urgent care visit or an emergency room visit. And treatment decisions are nuanced. Not all patients require antifungal therapy. Decisions depend on host risk, severity, and trajectory. And it requires reassessment, and it is not protocolized prescribing. So as Dr. Karmarkar already shared with us, symptoms overlap with other conditions. And because symptoms overlap with other conditions, confirming valley fever or Cooksey requires targeted diagnostic testing rather than clinical features alone. And we already saw some evidence to this, but there have been several studies which have shown that testing for valley fever is very, very limited in the ambulatory settings. This open forum infectious disease survey that was published in OFID in 2020, over 1,200 healthcare providers were surveyed, and how often clinicians were testing for valley fever. Only 3.7% providers actually reported frequently testing. Almost 70% said they never or rarely tested for valley fever, and this included endemic counties in California. And the other study from Arizona, where they checked the clinical practice patterns that resulted in diagnosis before or during hospitalization, 73% of Cooksey diagnosis happened during hospitalization, only 22% ambulatory care clinics, 3% emergency rooms, and 0.5% urgent cares were actually testing for valley fever. So bottom line is we need improved testing among primary care, urgent care, and other outpatient practitioners. So CDC and IDSA collaboratively published this clinical testing guidance aimed at primary care and urgent care providers to address this diagnostic gap. So as you can see, anybody who has been diagnosed with community-acquired pneumonia or who are not responding to a course of empiric antibiotics, or anybody with an initial presentation of CAP or erythema nodosum with a recent respiratory illness from these areas, which are Cooksey-prone areas, even if they just visited briefly, they need to be tested for Cooksey. So you should consider serological testing by enzyme immunoassay with immunodiffusion and complement fixation for confirmation. So again, anybody who has an initial presentation of CAP or erythema nodosum with respiratory illness, in those who have lived or visited the endemic areas, or anybody with a CAP or unknown agent that's not responding to antibiotic therapy, consider serologic testing with EIA. And if the EIA testing is positive, we consider them to have pulmonary Cooksey, and we confirm that with immunodiffusion and complement fixation, which here I'll go over in a little bit more detail. So there are several diagnostic methods available. It's not like we don't have diagnostic methods available. We just don't have a single perfect test. So we need to understand where these diagnostic tests are helpful and use them in context for your patients. So other than serology, there are cultures, pathology, antigen detection, and molecular methods available, while serology is the primary tool in ambulatory settings. So if you're seeing a patient in your primary care office, emergency room, serology is your primary tool to diagnose these patients. However, in hospitalized patients, patients who are severely ill, where you're able to obtain specimens for culture or pathology, the other diagnostic methods such as culture, pathology, antigen detection, as well as PCRs become helpful. But I'm going to spend most of my time only on serology because I'm, again, targeting towards those mild to moderate illness patients that are seen in the primary care and urgent cares. So the choice of tests really depends on where you see them. So if you're seeing them in your office or in an urgent care ambulatory setting, most of these patients who are mild to moderately ill, they are not able to produce a sputum, and you need specified BSL-2 or 3 safety labs for culturing as well. So your diagnostic method of choice becomes serology. So in immunocompetent patients, serum IgM antibodies appear within 1 to 3 weeks of symptom onset, followed by IgG antibody production. So available tests to detect these antibodies are 3: EIA, immunodiffusion, and complement fixation. There is a lateral flow assay that is available as well, which in the initial stages, the sensitivity was not as good, but there are more tests that are coming up. So hopefully we'll have a more robust lateral flow assay in the near future. But for now, the 3 main assays that we use in clinical practice are EIA, immunodiffusion, and complement fixation. Now, these assays have varying sensitivity, specificity, and diagnostic roles, which I'll go over here in a second. One thing I want to remind the audience about Cooksey is if you have antibodies, it usually suggests an active or recent infection. Levels typically decline and may become undetectable in most patients who resolve their infection. So it doesn't stay lifelong in many of these patients. So EIA is your first-line serological test. Several commercial kits are available. It's highly sensitive, but IgM EIA can yield false positives, so you have to be familiar with that. Antibody development may lag by several weeks. So this is one thing I want the audience to take away from this, especially in immunocompromised host. A negative result early does not exclude disease. Repeat testing is recommended if the suspicion is high. And we have seen lower sensitivity in immunocompromised host, as low as 55 to 60%. Just an example for a case that we saw here. This is a 31-year-old male post stem cell transplant 2 years ago. He presented with fever, cough, right lower flank pain. He was started on intravenous antibiotics, and Cooksey testing was sent 5 days later. And this is his CT scan where you can see the nodular infiltrate in his right base. And so he's immunocompromised. He's post-transplant. His Cooksey test that was sent within about 10 days of his presentation, 10 days of his symptom onset, was completely negative. So the EIA was completely negative, and his immunodiffusion and complement fixation were negative as well. But both his bronchoscopy cultures as well as his blood cultures grew the Cooksey fungus. So very, very illustrative case where early on, even with very severe valley fever, where this patient was fungemic, still, because he's immunocompromised, he's not produced an EIA response or an immunodiffusion or complement fixation response. So in these severely ill immunocompromised patients, you want to rely on multiple methods of testing to diagnose these patients. Immunodiffusion is less sensitive than EIA. It detects antigen antibody by visible precipitation bands on diffusion plates. This is your serological confirmation test. So this is the role of immunodiffusion, is confirming EIA test that's been used for screening early on. Again, may be negative or equivocal early on. So it's important to repeat the test if your clinical suspicion is high. So the current confirmatory serological method of choice is immunodiffusion. Another patient, 45-year-old construction worker, which we had seen here in our center. He had fevers, chills for 2 weeks. He was seen in urgent care. He was discharged, given antibiotics. Then he came back with persistent symptoms. You can see that large left-sided infiltrate there. And his EIA was positive. Later, his immunodiffusion came back as equivocal, and the complement fixation was still negative. So again, understanding the kinetics of these diseases, serological tests, even in early disease, even in an immunocompetent male, it can this patient was immunocompetent. He didn't have any underlying immune suppressing conditions. The EIA picked it up, but the immunodiffusion can still take time. So you have to understand that you need to repeat these tests in these patients when they are not positive early on. And of course, his bronch cultures were positive for valley fever as well. The role of complement fixation, which is a third serological test to be aware of, is not for screening or diagnosis. It's mainly for disease staging, prognosis, and treatment monitoring. So higher numbers are often seen in disseminated or chronic pulmonary disease, such as about 1:16 or 1:32. Titers usually peak 1 to 2 months after diagnosis and decline more slowly in chronic and disseminated diseases. I've often seen residents tell me that complement fixation was negative, so they don't have Cooksey. Again, remember that this test is not used for diagnosis or screening. It's only used for follow-up and monitoring. So your screening test is EIA, your confirmation test is immunodiffusion. You want to use the complement fixation only for staging and monitoring of these patients. 25% of uncomplicated pulmonary cases will never have a positive CF titer. Another example, this is the first case that I had shared earlier, our patient with severe disease who had succumbed to valley fever. His EIA was positive, his immunodiffusion was positive, but his complement fixation remained negative, despite the fact that he was actually fungemic with Cooksey. So again, quickly about serology, use EIA to screen, use immunodiffusion to confirm, and use complement fixation to monitor. If your patient is immunocompromised, if they are severely ill, hospitalized, try to obtain other methods of diagnosis as well, such as culture, pathology, or molecular methods. Just quickly about disseminated disease, as Dr. Karmarkar had already mentioned, disseminated disease can sometimes happen without the preceding pulmonary disease. So these are 3 cases that we had come across, each with difference. So the first case was a patient with spinal disease, whose spinal disease happened after the resolution of their respiratory symptoms. So the respiratory symptoms were not diagnosed as Cooksey. She went on to be symptomatic with that for a few weeks and then resolved. And then a few months later, she developed her spinal disease due to Cooksey. The second patient had concomitant respiratory symptoms and skin disease. Both of them went undiagnosed for a period of time before the diagnosis was made. And this third patient had undiagnosed CNS disease with severe complications. He never had preceding respiratory symptoms. So you want to remember that preceding respiratory symptoms may not be present in these patients. You still want to diagnose the disseminated disease in these folks. So typically occurs, the one thing is disseminated disease occurs very early in the course, within weeks to months of the initial pulmonary infection, and may be clinically evident at the time of pulmonary diagnosis, but it also occurs in patients whose primary infection was mild or never recognized. And late dissemination is uncommon in those who have not received antifungal therapy. However, in folks who have received antifungal therapy, we do see delayed dissemination happen up to even 2 to 4 years after the antifungal therapy was stopped. So it's important to monitor these folks for much longer time, even after their treatment completion. So because of the nonspecific nature of these symptoms, disseminated disease is also often diagnosed late. And I also want to mention there is currently no evidence that treatment of primary pulmonary Cooksey reduces the risk of extrapulmonary dissemination. So I just want to reiterate that one more time. Right now, we don't have any evidence that suggests that if I treat primary pulmonary Cooksey with antifungal therapy, I can reduce the risk of extrathoracic dissemination. So which makes moving on to management. So once we've already shown that diagnosis is hard, but once I've diagnosed the patient with valley fever, it doesn't automatically mean I'm going to treat them. As I mentioned, just treating is not going to prevent dissemination or improve symptoms. So treatment decisions are based on 2 main things, is their risk factors and the severity. So those 2 are the main drivers of whether I want to treat this patient or not. Most immunocompetent patients will recover without antifungal therapy. We do treat moderate or severe disease, or we treat patients with risk factors, and I'll say what they are, regardless of the severity. So if you have a high-risk patient, such as cellular immunodeficiency, transplant, chemotherapy, HIV, biological agents, pregnancy, 2nd or 3rd trimester, certain racial risk factors, such as African-American, Filipino, Hispanic, Latino, some of these patients, even if they don't have symptomatic disease or if they don't have severe disease, we may still consider treatment in those patients because of the risk of developing disseminated or high-risk, high-severity disease. Some would consider a titer of more than 1:16, 1:32, high enough to start treatment as well because of the risk of dissemination. So the next step is, so once the first step I do is assess their risk. So I see if they have those conditions or not. If they have any of the high-risk conditions, I'm going to treat them. If they don't have high-risk conditions, the next treatment decision is based on the severity assessment. So we want to assess whether it's mild, whether it's moderate, or whether it's severe. Moderate disease is any of the following: if they have 10% weight loss, if they have intense night sweats for more than 3 weeks, if they have symptoms persisting for more than 2 months, more than 50% of one lung or bilateral lungs are involved, prominent or persistent hilar lymphadenopathy, CF antibody titers more than 1:16. Some would say 1:32. Functional impairment and inability to work. So all of these would fall under moderate disease, and I would consider treatment for those. Severe diseases are illnesses requiring hospitalization, respiratory compromise for hypoxemia, clinical deterioration, or exacerbation of their underlying comorbidities. So mild are those who do not meet any of the moderate or severe criteria. So if you have mild disease that doesn't fall into any of those criteria, and you don't have any of the high-risk conditions that we talked in the previous slides, those patients may not need treatment. So mild primary pulmonary disease, no antifungal therapy is needed. In most healthy patients, they would recover without complications. We would consider azole therapy with fluconazole if they have high risk factors. And there are 2 observational studies which actually showed no faster symptom resolution with treatment versus observation in this group of patients. And there was no reduction in dissemination as well in this low risk patients. What we did see, though, even though it was a small number, was there was a risk of delayed dissemination reported after stopping therapy for these patients. So right now, the evidence for early empiric antifungal therapy in mild primary disease remains limited and inconclusive. Early treatment may delay rather than prevent dissemination, with relapses reported up to 4 years after stopping therapy. Moderate pulmonary disease, we would treat with an oral antifungal such as fluconazole, which is a primary modality of treatment right now. Other option would be itraconazole. Treatment is approximately 12 weeks, but is guided by clinical response, serological response, and imaging findings. Fluconazole is favored because of absorption, safety, and fewer interactions, but itraconazole is a reasonable alternative as well. Severe disease typically need hospitalization. Then if they would typically need intravenous amphotericin B, and then once they're clinically stable, will transition to an oral azole. Immunocompromised hosts, we use the same principles, but typically they need longer duration of therapy. We want to reduce immunosuppression when feasible. HIV patients, we want to start them on ART promptly, and we want to avoid azoles in the first trimester of pregnancy. I think this is the most important slide I really want to highlight on is the longitudinal follow-up. Everybody with valley fever, whether they are mild or moderate or severe, whether they needed to be treated or not needed to be treated, needs to be followed up. All patients with valley fever need that longitudinal follow-up to monitor for complications. So if you have untreated mild disease, reassess usually about every 2 weeks initially if improving, and then monthly for every few months. Uncomplicated, untreated mild infections can be considered resolved by around 2 years. So they still need monitoring those for several months. If you have a treated moderate or severe disease, chest imaging and serology, typically every 3 to 6 months during therapy. Continue monitoring for 2 to 3 years as extrapulmonary disease can appear later after the treatment has been stopped. All disseminated cases require antifungal therapy. Surgery may be needed for airway obstruction, cord compression, or abscess formation. Meningitis patients often need ICP management. Shunts are often required. For milder disseminated infection, oral azole therapy may still be appropriate, but severe or refractory cases may need amphotericin. For meningeal involvement, lifelong therapy is required. Severe spinal disease, vertebral disease often end up requiring lifelong therapy as well. Refractory disease options include posaconazole, Bori, isavuconazole, and some newer investigational agents such as Ellora foam. With that, I'm going to stop and hand it back to Ellora if you want to share any of the other resources, Ellora.
Great. I also want to make sure that people have time for questions. So I'm just going to throw up a couple slides here. So I just wanted to highlight that in addition to your local clinical partners, there are a lot of other resources available that can provide clinical consultation. We have a website at couldbevalleyfever.org where you can see our data dashboard and other publications related to data, as well as prevention for outdoor workers and employers. We have a dedicated provider webpage with some of what we talked about today, as well as links to various guidance documents that can sort of be a one-stop shop for providers who want to look up more information. And so please feel free to reach out to any of us during this presentation, Dr. Siva Subramanian, our local health department partners, as well as the CDPH Cooksey team with any questions or concerns, assistance with outreach, or reports of possible clusters. That is it for the presentation. Thank you so much for your attention.
Thank you so much. I know it went for a full hour. Yeah. There are a few questions online, but if there's any questions in the audience here.
So in patients who have disseminated Coccidioidomycosis, what is the mortality rate from it? And
Mortality rate for meningitis without treatment is 100% fatal. So with treatment, the mortality for meningitis may go close to 30 to 40%, but that's the highest mortality rate is with meningitis. Cutaneous and spinal disease is more morbidity rather than mortality. The other mortality that we are seeing is with acute Coccidioidomycosis when they come in with ARDS and severe infection from that.
And what percentage of patients go from mild disease to severe or disseminated disease?
It's very unpredictable. And so right now, I would say about 1 to 5% can go on to develop disseminated disease, but that's the 1 to 5% of the reported cases that we know. There's still that denominator that goes unreported that we are not familiar with what's going on. But I would say about 1 to 5%.
Does recovery from an uncomplicated, moderate infection in an otherwise healthy person, does that confer any degree of immunity or alternative any greater susceptibility
That's a fantastic question.
to a new infection?
It's a fantastic question. So actually you do develop lifelong immunity following your first infection. So that's why it's a perfect candidate for a vaccine as well. So the risk of a new infection being acquired after you have recovered from the first infection is very low. The follow-up and longitudinal monitoring is to prevent the relapse of the infection that you've already acquired. There are some questions online that I think that would be great for our public health partners to talk about. So I don't know if one of you guys want to take this. What efforts is Fresno County doing to educate residents in western part of the county because of their higher exposure to valley fever and protective measures? Matthew or Gail or Ellora, do you want to take this?
Yeah, I can try to answer that. So yeah, we do health education out in those communities, trying to target those high risk groups. As from the public health perspective, just creating awareness of Coccidioidomycosis and making sure if they're in those high risk settings that they mask appropriately if they're in a high dusty area, and just trying to get the word out that there's a risk for the disease in those communities.
Matthew, related to this, the other question was about the active landfill operations going on, and whether there have been any assessment of valley fever exposure risk in communities that live in close proximity to those landfill operations.
Yeah, I'm not familiar with that, so I can't answer that. I'm not familiar with the information on that.
Thank you. And then the other question was in Merced, Dr. Santana, is there any correlation to road work or construction and increase in the incidence of Coccidioidomycosis?
Nothing that I'm aware of myself. However, this presents a great opportunity to conduct research as Coccidioidomycosis relates to those specific environmental exposures and occupational exposures. So if one of the med students on the call or there in person would be potentially interested in something like this would be the perfect research project.
Great, thank you. And then Gail, I think this question is, what soil depths and conditions yield best Coccidioidomycosis detection?
That's a tricky one. I think from my understanding, and I have not personally done soil sampling, although we have worked with a number of partners who have done so, my understanding is that they often sample within the top few inches of the soil. I don't know a lot about that. I do know that a lot of soil sampling has looked at associations between rodent burrows and valley fever, and sometimes they're more likely to find it in areas with a lot of rodents. But in general, soil sampling for Coccidioidomycosis is very challenging. So it's not something that's commercially available and is still kind of in the research realm of things. So that's about the limits of sort of my confident understanding about it. And then I did quickly to just want to comment on some of the questions about associations between valley fever and dirt disturbance. We have had a number of outbreaks among outdoor workers on sites where dirt's being disturbed, like construction. So in that realm of outdoor work, we have outbreak investigations that have been done. We have a lot of data that's been collected. But unfortunately, when we get reports of valley fever, we get very little data on those patients. So it's very hard for us to associate it with a particular event. So we are doing some modeling studies with academic partners to look at land use. We're exploring some sort of like mapping platforms to start trying to understand this. So it's on our radar. We're doing what we can, but right now the data we have is pretty limited to the impact on the outdoor workers. So we're trying, we're working on it.
Yeah, I know we are almost over time, but I just had a quick question for Dr. Papa. Since we're seeing higher amounts of cases now in Stanislaus, which was not traditionally a very endemic county, but now the cases are increasing, are you noticing more lag of testing? Is there any room, do you feel, for the need to bring this up more with the ambulatory care settings for more testing? What are your thoughts on that, Dr. Papa?
Yeah, I mean, I think that's definitely what we're trying to do, is just to make increased awareness, certainly of that we are seeing increasing rates overall in our county, but especially the areas of our county where, especially like as I noted on the west side, where we are seeing really large increases in the rates of Coccidioidomycosis, to make providers aware of that.
Great. Ellora, do you want to take the question on the skin test? What are your thoughts on?
I actually am going to punt that one to Gail because she's been doing this for 13 years and I think has a lot to comment on the use of skin tests over time.
So what I can say about the skin test is back more so in, I think, like the 50s to the 70s, there were some skin tests that were being used to understand the prevalence of valley fever. And unfortunately, that's really the most recent data we have on prevalence is from that time period. Then the skin test stopped being used. And there is a new skin test that's being used that was FDA approved, but really so far it's only been used specifically, honestly, in the California correctional population has published some data on the use of that skin test. And I think they had some mixed findings on how useful it was for prevalence studies. So we do have a test now. I think designing a study to look at prevalence is a big undertaking that's on a number of researchers' minds. So we don't have those updated numbers, but I think there is work being done to try to update those prevalence studies now.
I'll also add that I think corrections is still in the process of publishing additional results, but there are some concerns that those skin tests are not necessarily the most reliable for picking up active infection. And it's also not necessarily reliable to detect if someone has had infection in the past, because sometimes responsiveness to that skin test wanes over time with age. So it's a little bit of a tricky one to use and interpret, which is why generally we recommend starting with serologic testing, as Dr. Sivasubramanian mentioned.
Great. Any other questions? All right, thank you everyone for joining, and thank you to all the online audience as well. Sorry, we went over a little bit, but I think we covered a lot today. Thanks. Thank you. I think I got more of the questions.
Yeah, great job. Good job at throwing them.
Yeah. Yeah. They really wanted to, because there was a lot of them from their counties attending too.
Yeah.
So they kind of wanted to show that they.
Looks like a number statement.